as Carrie said, I'm Dr. Amanda McKinney. My background is actually in obstetrics and gynecology and in female pelvic medicine and reconstructive surgery. But about 8 to 10 years ago, I got involved in lifestyle medicine. Kind of got tired of all of the chronic diseases that we were seeing and not being able to do much about it. And as an obstetrician gynecologist, it was making my life very difficult because on the obstetric side, we were seeing a lot more patients with high-risk pregnancies, obesity and hypertension and diabetes and preeclampsia and all those things. And we were seeing worsening fetal outcomes as a result of that. It was also making surgical procedures physically harder. To operate on somebody who weighs, 300, 350 pounds is very difficult. And a lot of, on the gynecological side, a lot of the things that we were seeing in terms of cancers, in terms of dysfunctional bleeding, all those kinds of things, also, again, primarily lifestyle related. So I got involved with the American College of Lifestyle Medicine. I got board certified in lifestyle medicine. And I left practice about 2 years ago in order to start doing lifestyle medicine full time. So I'm at Doane University now, and I created a series, a certified lifestyle medicine program that it's 30 CMEs. If you take it, it allows you to sit for the board exam, the American Board of Lifestyle Medicine board exam. And we're also doing work with certified lifestyle medicine executive training for people who are so physicians and nurse practitioners and whoever that are trying to navigate our current health system and how they can affect change within our current healthcare system so that we can implement that. So today I'm going to be talking about atherosclerosis and angina. And I'm going to give an overview again of lifestyle medicine just in general. And lifestyle medicine is, by definition from the American College of Lifestyle Medicine, it involves the use of evidence-based lifestyle therapeutic approaches, such as a predominantly whole food plant-based diet, exercise, sleep, stress management, alcohol moderation, and tobacco cessation, and other non-drug modalities to prevent, treat, and oftentimes reverse the lifestyle-related chronic disease that's all too prevalent. And what we know is that fully 80% of the healthcare dollars, the medical care dollars that we spend in this country are on chronic diseases of lifestyle. So the vast majority of these chronic diseases are the result of the feet, forks, and the fingers, right? So feet, physical inactivity; forks, what we elect to put in our mouths 3 times a day or sometimes more often than that; fingers, whether or not we choose to smoke; and then also by sleep, disordered sleep, lack of sleep, stress, and lack of interconnectedness in our lives. So from the Global Chronic Burden of Disease study, that number 1 is forks. So what our diets are the number 1 cause of morbidity and mortality in this country, followed second by smoking. So heart disease kills more Americans annually than all of our past wars combined. And 25% of the time, the first symptom of cardiovascular disease is sudden death. So 55% of men and 68% of women who die of sudden cardiac death have no prior warning of significant heart disease. And heart disease is the number 1 killer of all those over the age of 35, with cancer as a close second, except for when you can see when people hit about 65 to 70 years old, cancer mortality drops off significantly and heart disease continues to rise. So, and treating heart disease is a really expensive proposition. So in 2018, the cost of treating heart disease, I didn't update this, but it was about $200 billion. And cancer treatment was about $124 billion. And it's expected that heart disease treatment will triple to about $545 billion by 2030, and that's according to a policy statement by the American Heart Association. And this spending accounts for 1 in 6 of every healthcare dollar that we spend in the U.S., the majority of which is spent on diagnostic procedures and treatment with angioplasty and such. And in lifetime spending, so a person with heart disease will oftentimes spend $750,000, sometimes approaching $1 million just for their personal care. And heart disease actually begins in childhood. So studies of accidental death victims between the ages of 3 and 26 found that fatty streaks, which are the precursors to these atherosclerotic lesions, are universally found in children by the age of 10 in this country. And there were also Italian researchers that looked at arteries of miscarried fetuses and found that these fetuses of women who had high LDL cholesterol also had fatty streaks in their arteries in the womb. And in addition, autopsy studies of American soldiers that died in the Korean War revealed that 77% of these young men, whose average age was 22, had visible evidence of coronary atherosclerosis. And some of them had arteries that were blocked 90% or more. And all these studies reveal that in a dramatic way, that atherosclerotic changes appear in the coronary arteries years before symptoms ever appear. So again, just as we just discussed, the fatty streak is the earliest visible lesion of atherosclerosis. And it's accumulation of lipid-laden foam cells in the intimal layer of the artery. And then you start to get infiltration initiation of atherosclerosis is in response to endothelial injury, and it's mediated by inflammatory cytokines. And often, atherosclerosis preferentially affects areas like arterial branch points where the flow is more turbulent. And this leads to endothelial dysfunction. And the endothelial cells produce nitric oxide, which is a potent vasodilator. It's also got anti-inflammatory properties. And so when the endothelial cells are damaged and you don't get that nitric oxide production, you get progression of these lesions. Then you get further migration of T cells and monocytes into the subendothelial space where they get converted, the LDL gets oxidized, they get converted to foam cells, and the thing starts to grow. Okay. And over time, these foam cells produce pro-inflammatory cytokines that then recruit smooth muscle cells into the media from the intimal layer, and it causes that thickening of the intimal layer. And so when we talk about atherosclerosis, so the athero is coming from the atheroma portion of it, which is that accumulation of the fatty lipids. And the sclerosis part is that intimal thickening that causes the artery to become stiffened. So at this point, you can get a fibroatheroma or a plaque, and these plaques can either be what we call stable or unstable. And so depending on the milieu, the corporeal milieu, sort of the environment in which it's residing, if there's a lot of inflammation going on from the dietary factors, then you can get an unstable plaque. And so what happens is this fibrous cap over the top of the fibroatheroma becomes thinned, and these things can become unstable, versus a more stable plaque, which is that fibrous cap. The inflammation tends to subside. That fibrous cap starts to sort of thicken, and it just kind of sits there. So when these fibroatheromas, if they occlude the vessel more than 50% or so, then you tend to get symptoms like, and it's a stable plaque, you tend to get symptoms more like stable angina. So in other words, it's very predictable. You have patients that will have exertional angina versus an unstable plaque that can cause a heart attack, which is the vast majority. So the vast majority of heart attacks, somewhere around 70 to 80%, are actually caused by these smaller, unstable plaques. And these smaller plaques tend to occlude the lumen by 35 to 45%. So those are the ones that cause most of the heart attacks. And we're going to talk a little bit about more why that's important later here. So again, as I said, these unstable plaques are the ones that tend to cause heart attacks. And if you have an inflammatory type situation in the body, right, from dietary factors and so on, it can cause thinning of the plaque, which then the sheer force of the blood running over the top of the plaque will cause the plaque to open. All of the goo inside sort of extrudes. And then it causes a clotting cascade where all the platelets and the white blood cells come to the rescue, which then causes the vessel to obstruct, causing potentially a heart attack. Or the clot can embolize further downstream and cause an infarction somewhere else. In some cases, a temporary increase in emotional or physical stress precedes the final triggering event, and other recognized recognized triggers include physical and sexual activity, anger, anxiety, work stress, earthquakes, war, terror attacks, temperature changes, and cocaine use. And there's also appears to be a link to circadian rhythm, which also is why heart attacks might be more common in the morning. And interestingly, dangerous eating can also lead to destabilizing a plaque, leading to rupture and thrombosis. So autopsies of people who die from heart attacks have revealed cholesterol crystals actually protruding from the ruptured plaques. So the researchers hypothesized that when a soft atheromatous plaque with large lipid deposits becomes supersaturated with cholesterol, it can undergo a physical transformation where the cholesterol actually crystallizes. And this is an actual, well, it's a picture of a crystal, but anyway. It actually crystallizes, breaking open that plaque and then causing the event to occur. And so they think that this is why we actually see, because there's always been this phenomenon that heart attacks are more common around times of holidays. And they thought that it was, well, it's, Thanksgiving and Christmas, there's oftentimes snow, and so people are out there shoveling snow, and that's what's causing them to have the heart attack. Actually, that phenomenon is in warm weather places like Los Angeles that doesn't get any snow, so that's not a very good explanation. But what they actually think is that, you sit down to these big meals, they're full of dietary fat and cholesterol, causes a supersaturation in the atheroma, plaque ruptures. And it tends to be particularly responsive to a meal that's of eggs. So eggs are very high in cholesterol, and they tend not to raise, a meal with eggs tends not to raise the blood cholesterol significantly, except right in the period right after a meal that's heavy with eggs. So dangerous eating patterns can also precipitate a heart attack in somebody who's got a plaque. Okay, regardless of the cause, once the plaque ruptures, the plaque contents are exposed to circulating blood, triggering thrombosis. And the resultant thrombus can be incorporated into the plaque, changing the plaque's shape and causing its rapid growth. It can occlude the artery. It can rapidly occlude the vascular lumen and precipitate an acute ischemic event like a heart attack or stroke, or it can embolize and wash downstream. But the clinical consequences of a ruptured plaque can include sudden cardiac death and death of myocardial muscle to varying degrees, and it's dependent on the plaque location, obviously, and a relative balance of the procoagulant and anticoagulant activity in the blood, as well as the vulnerability of the myocardium to an arrhythmia or dysrhythmia. So atherosclerosis is initially asymptomatic, and it's often is so for decades, as we know. If this is starting at age 10, right, it's going on for a long time. So symptoms and signs develop when the lesions impede the blood flow. So Transient ischemic symptoms like stable exertional angina, like we talked about, and intermittent claudication are typically developed when the stable plaque occludes the arterial lumen by more than 70%. Severe or complete stenosis can also result from vasoconstriction of a lesion that does not entirely limit blood flow. So if you've got a lesion that's occluding by 50% or more, and then you've got endothelial dysfunction, and so your vessels aren't producing, the endothelial cells aren't producing nitric oxide, and you have an event that causes a vasoconstriction, then patients can oftentimes have symptoms because it'll occlude the vessel enough to impede the blood flow. So stable angina. So when we talk about atherosclerosis, we have chronic, and then we have the acute coronary syndromes. So chronic is really that stable angina, and then our acute coronary symptoms are myocardial infarctions and unstable angina. And unstable angina is when a patient will have chest pain at rest, so it's not necessarily associated with exertion. And both of those things, both of those acute coronary syndromes are considered a medical emergency. So stable angina is relatively easy to diagnose. However, prediction of those that are at high risk of a plaque rupture is really problematic. Stress tests only pick up plaques that obstruct by 50% or more. But again, 70-80% of all heart attacks are caused by plaques that are not obstructive or visible on angiography or stress tests. Because again, they're only occluding the lumen by about 35 to 40%. So when imaging techniques such as invasive coronary angiography or CT angiography are used to view the coronary artery vessel wall, areas of plaque that are too small to impede blood flow will show up in only about 30% of people that are referred to testing who haven't been diagnosed with heart disease. Other various imaging technologies are currently being studied as a way to identify plaques, especially those that are vulnerable to rupture. CT angiography is often used as an initial screening test, but catheter-based tests, including intravascular ultrasonography, which uses a little ultrasound transducer on the tip of a catheter to produce an image of the inside of the arterial wall, angioscopy, plaque thermography, which detects an increased temperature in these plaques, and optical coherence tomography, which uses an infrared laser light to localize vulnerable plaques. All these techniques have been sort of examined. And some clinicians also use serum markers for inflammation, like the high sensitivity CRP, and anything over 3 milligrams per deciliter is considered elevated risk. And predictive. There's also the Framingham coronary risk predictor, a 10-year coronary risk prediction tool, but it tends to highly overestimate the risk of an event. So all of these problems with, that doesn't show very well. All of these problems with predictability led Louis Culler, who was a physician and a professor of public health from the University of Pittsburgh. It led him to say, after his 10-year cardiovascular health study, that all males who are 65 years of age and older who have been exposed to the traditional Western diet have cardiovascular disease and should be treated as such. So basically, it's saying it's universal. Okay, in addition, family history is problematic because it can be useful when heart disease is present, but the absence of a positive family history doesn't rule out risk because heart disease is not genetic. And we know this both from epidemiologic studies as well as autopsy studies. So Dr. T. Colin Campbell, who wrote the China study, and his co-researchers investigated the eating habits and incidence of chronic disease among thousands, hundreds of thousands of rural Chinese. And in Guizhou province, which is a region that comprises about 500,000 people, over the course of 3 years, there was not one single case of coronary artery disease among men under the age of 65. And likewise, British and American physicians who were working in Uganda during the 1930s and 40s described the incidence of coronary artery disease as almost non-existent. And autopsy studies of age-matched Ugandans confirmed this observation. They did a study where they had 632 autopsies of Americans, and in those 632 Americans, there were 136 heart attacks, but there were 0 heart attacks in a group of 632 Ugandan autopsies. Another Ugandan autopsy study revealed that there were 0 fatal heart attacks out of 800 autopsies performed with only 1 non-fatal heart attack identified. So this low rate of heart disease in rural China and Africa is thought to be because the average cholesterol level in these folks is about 150 milligrams per deciliter. Okay? In this country, we say the average cholesterol level is 200, and we say that anything 180 is great. Well, it's not. So a third of all heart attacks actually happen in people who have a cholesterol of 170. Let's see. Okay. We also have evidence from the North Karelia project. So North Karelia is an area in Finland that in 1972 they were number 1 in terms of cardiovascular death globally. We were number 2, they were number 1. And they decided that that was unacceptable. So they initiated community projects where they were working to get cholesterol levels down. And the way that they had to do that was to get people to reduce their saturated fat consumption. So because this was in the era before statins. Statins didn't exist. And saturated fat intake is what actually causes your cholesterol levels to go up. So they implemented several different community initiatives, but they got people to reduce their pork consumption and their butter consumption. They also went so far as the government subsidized dairy farmers to switch from dairy farming to berry farming to try to change the dietary habits of the people there. And that's kind of what this project is better known for, is the Dairy to Berry project. But it was unbelievably successful. So they did a 25-year follow-up, and what they found was that in the North Karelia area specifically, they had an 85% reduction in cardiovascular mortality. So statins can't do that, just saying. So they had, it was unbelievable. They also were working on trying to get people to stop smoking. So there were they had a really high rate of smoking there. So those two things combined, smoking and saturated fat consumption reduction, it had this great impact on cardiovascular mortality, but it also, they had a 46% reduction in all-cause mortality because of the reduction in cancer death. And they had an increased life expectancy of 7 years for men and 6 years for women. So, so the presence of atherosclerotic disease in one vascular territory increases the risk of the disease in other vascular territories, right? So this isn't just an isolated thing. So it can lead to dementia and strokes. It can lead to degenerative disc disease and sciatica. It can lead to sexual dysfunction in both men and women, as well as claudication. And patients that have non-coronary atherosclerotic vascular disease have cardiac event rates that are comparable to those who have known coronary heart disease. And so it's considered a cardiovascular disease equivalent or coronary artery disease equivalent, just like diabetes is. So treatment historically has largely relied on drug treatment of diagnosed risk factors with medications such as statins, ACE inhibitors, beta blockers, antiplatelet drugs, and with a focus on lifestyle changes being relatively modest. However, the only critical risk factor for atherosclerotic plaque buildup is an elevated serum LDL. So autopsies of thousands of young accident victims have shown that the level of serum cholesterol correlated to the amount of atherosclerosis in the arteries. So to become heart attack proof, evidence has shown that an LDL of less than 70 must be achieved. The only way to do this is either lifelong high-dose statins or a whole food plant-based diet. So other lifestyle changes should also be considered, including smoking cessation, regular moderate physical activity. But historically, drugs that have been used to treat dyslipidemia, hypertension, and diabetes have required dietary modification. And these other lifestyle changes directly or indirectly improve the endothelial dysfunction, reduce inflammation, and improve clinical outcome. So, oh man, doesn't show up well. Okay, so the body has this innate capacity to heal itself, right? So this is something we've known for a long time. You know, if you have an injury, you know, so if you have a scab and your kid keeps picking it off and they say, keeps bleeding, well, stop doing that, right? Stop doing that. Stop injuring it. And we know that if you're a smoker and you quit for 15 years, your risk of lung cancer now approaches that of a lifelong non-smoker. So because of a body's ability to heal itself, reversal of coronary atherosclerosis is possible, and it's been demonstrated by the work of both Dr. Caldwell Esselstyn and Dr. Dean Ornish. And according to Dr. Joel Fuhrman, all heart disease is reversible with the exception of approximately 1% who has advanced valve damage, a genetic defect, or electrical pathway disease. So sometimes we refer to this as the best kept secret in medicine. Those of us in lifestyle medicine refer to it that way. But in Dr. Esselstyn's original study, they followed 198 patients with established cardiovascular disease. And these patients were counseled and transitioned to a plant-based diet which was completely devoid of dairy, meat, fish, anything with a mother or a face, and oil. And nuts, actually. They took away nuts, too. And of those 198 patients, 89% were adherent to the diet. And of those adherent patients, there was only one major cardiac event, which was judged to be recurrent disease. So that left it was a stroke, and so the recurrent event rate was 0.6%. Contrarily, the 62% of non-adherent patients experienced an adverse event. And both Drs. Esselstyn and Ornish have demonstrated angiographic evidence of plaque regression. So this was the study that was done by Dr. Ornish, and what they found, so what they looked at was intensive lifestyle changes over 5 years, but they looked at vessel diameter. So when in the two different groups, there was a 3% reduction in the intervention group, there was a 3% reduction in plaque size, so it opened the vessel lumen by 3%. And that actually translates to a 6% increase in flow. So that's important because 91%, that's obviously enough to improve symptoms, because 91% of the patients that were adherent to the diet had resolution of their chest pain within 12 weeks. So we also talk about atrial fibrillation, and this affects about 2.5 million people in the United States. And we know that cardiovascular disease is an important risk factor, but hypertension and diabetes and obesity, obstructive sleep apnea also can promote atrial fibrillation as well. So what's only recently been discovered is that reduction of obesity and control of these other risk factors can significantly improve the management of atrial fibrillation as well. And there was a study that showed that about 10% or greater weight loss resulted in a 6-fold greater probability of arrhythmia-free survival compared with controls. So catheter ablation of atrial fibrillation has evolved as an effective therapy for it. But we know that the ablations tend to work better in people who modify these other risk factors. So symptoms of angina can also be resolved with bypass surgery and angioplasty. However, Neither treatment prevents future cardiac events or extends the lifespan significantly in those with coronary heart disease. So because these surgical procedures only treat a small minority of the plaque burden throughout the body, they relieve symptoms only temporarily and only in that one particular spot. So without treating the actual cause, the disease progresses throughout the rest of the coronary vasculature. And additionally, these surgical procedures are not without significant risk and cost. So the risks of bypass grafting include an increased risk of stroke and overall death rate, loss of mental function in the elderly, atrial fibrillation, and decline in mental function is the most severe right after surgery. So at the time of discharge from the hospital, somewhere between 50 and 80% of patients have acute mental decline. And even 5 years after surgery, a 20% reduction in mental function has been found in 42% of patients. An MRI study found that brain damage in 51% of patients after bypass, and 3 years post-op, a permanent reduction in mental capacity was identified in 31% of patients. Symptoms of this include sleep disturbance, nightmares, depression, mood swings, and loss of intellectual acuity. So current guidelines state that there's no significant data to recommend patients who have stable coronary artery disease that they should be evaluated with angiography or treated with either bypass or percutaneous interventions like stent. And this is because a recent meta-analysis of 28 studies comparing cardiac surgery with medical therapy found a less than 2% absolute improvement in survival achieved with surgery. And for older patients who are 80 years or older, the risks are even higher. So multiple studies have confirmed the higher risk of complications, death, and prolonged hospitalization in this group. And octogenarians' 30-day mortality rate is 9% compared to 1.2% for those that are younger than 80. And they also have a 3% longer hospitalization, a 51% increased risk of neurological complications, and are 49% more likely to undergo repeat surgery for bleeding. Percutaneous interventions, so this is angiography, sometimes with stenting, sometimes without. It carries a risk as well, including death, heart attack, stroke, ventricular fibrillation, and aortic dissection. So MI occurs in about 3 to 5% of patients during percutaneous intervention. And one study showed that about 1.2% of patients actually die. Bypass grafting, just like bypass grafting, the risks are higher in those over 70. So revascularization with PCI or thrombolytic can be life-saving during acute coronary syndrome, such as unstable angina with intractable chest pain or acute myocardial infarction. And according to the American Heart Association and the American College of Cardiology guidelines, revascularization is only appropriate when severe coronary artery disease is suspected to be the cause of depressed left ventricular ejection fraction or transient heart failure, or when severe coronary artery disease is expected as the cause of a ventricular arrhythmia. So if we were to actually apply those standards, we would prevent approximately 12% of all of these procedures. So there's more than 600,000 of these procedures done annually, and 12% were found to be unnecessary, and 38% were found to be questionable. Okay, so how should we be treating patients who have cardiovascular disease, angina, atherosclerosis, coronary artery disease? So again, LDL is the biggest risk factor. So in order to reduce LDL, the patient has to drastically reduce their intake of trans fats, and those are primarily in processed foods, but they also occur naturally in dairy and meat. They also need to decrease their intake of saturated fat, which is, again, primarily found in animal products, but also found in palm oil and coconut oil. And again, to a lesser extent, they also need to reduce their cholesterol intake. So it seems unusual to us that our dietary cholesterol levels are actually impacted by our saturated fat intake rather than our cholesterol intake. But cholesterol, again, as we said, it doesn't necessarily impact blood cholesterol levels except immediately after the meal, which can cause that cholesterol crystallization. But actual LDL levels are impacted by saturated and trans fats. And small changes in fat, small changes in fat intake don't cut it. Really, you've got to be less than 20 grams of fat per day, and most of that needs to be coming from polyunsaturated or monounsaturated fats. You've got to get the saturated fat to less than 2 grams a day, and trans fats need to be at 0. There is no safe level of consumption of trans fats, period. Now, again, there are trans fats that are naturally occurring in animal products, so eating small amounts of animal products, you're still getting trans fats in there. And again, your fats you want to be coming in whole plant form. So you can eat olives, but you don't want to be eating olive oil because you remove the fiber and some of the other nutrients. And oils have been shown to be inflammatory and actually to perpetuate cardiovascular disease. We also want people to eat more plants, whole plants. So plants have flavonoids and antioxidants. So things like red wine and berries and dark beers and some of those things have black teas. Also have all of these polyphenols and flavonoids that are especially protective. The Predimed study was a dose-dependent relationship. So every single serving of plants extended lifespan, and each serving of animal protein decreased lifespan. So cutting back on animal products by 2/3 to 1 serving a day instead of 3 reduced deaths by more than 40%. We also want to increase complex carbohydrates. So highly refined carbohydrates like sugar and high fructose corn syrup and white flour, those things are inflammatory. We want to reduce the consumption of those. But complex carbohydrates like whole oats or brown rice or quinoa or some of these other ancient grains actually reduce the risk of cardiovascular disease. Beans are especially important. They have fiber. They help control insulin levels. And then, of course, the green leafy and cruciferous vegetables. So green leafy vegetables have nitrates in them. So those get converted in the mouth and in the digestive tract to nitrites, which are then available for the endothelial cells to produce nitric oxide. Nuts. Okay, so we're going to talk about nuts for a little bit. So in studies of patients, not cardiovascular disease patients, but just in people, epidemiologic studies, those who eat nuts tend to have a lower risk of sudden death. They tend to have lower cholesterol. It also and avocados do the same thing, and it's about 1 to 2 ounces of raw nuts 5 times per week. Now, this doesn't include seeds. Walnuts are the best nut in terms of the ratio of omega-3 to omega-6 fatty acids. But in the studies with patients who have established cardiovascular disease, so if you're just working on prevention, so you don't have heart disease and you're just working on prevention, nuts are okay. But in patients with cardiovascular disease, there's some debate about whether or not nuts are advantageous or not advantageous. Now, if you ask Dr. Joel Fuhrman, he will tell you they should eat nuts. And if you ask Dr. Esselstyn, he said, no, they should not eat nuts. So that is, again, I don't know that we have enough evidence to say one way or another. But for people who don't have cardiovascular disease and are working on preventing, nuts are good. The other caveat about nuts is that they are a high-fat food, and so they tend to be very calorically dense. So for people who are trying to manage their weight, avocados and nuts are not necessarily a great choice. Seeds, flax seeds, chia seeds, all of those are fine for everybody. They have benefits in terms of having omega-3 fatty acids in them, and those are okay for everyone. Additionally, there was a study done where they fed patients Brazil nuts, and they gave them 4 Brazil nuts per month, because Brazil nuts are high in selenium, and so you don't want to overdo those. But 1 Brazil nut a week had the impact of lowering cholesterol by, what was it? I have to find the number. I think it was 20%. I'm not seeing it here, but I think it was 20%. Okay, alcohol. So alcohol increases HDL, but it also has some poorly defined sort of antithrombotic and anticoagulant impacts. And these effects appear to be the same for wine, beer, and hard alcohol when they're consumed at moderate consumption, which is 30 milliliters or 1 ounce of ethanol, which is the equivalent to about 2 average servings of a typical alcoholic beverage. 5 to 6 times a week does help protect against coronary atherosclerosis. However, at higher consumption levels, alcohol can actually cause significant health problems, as we all know. So the relationship between alcohol and total mortality is a J-shaped curve. So people who don't consume any alcohol at all have a little bit higher risk. Okay, not super high, but like here. And then when you start to have that, 1 to 2 drinks a day, you get down to the lowest mortality, and then above that, then mortality starts to increase in a dose-responsive fashion. So it's lowest for men who consume less than 14 drinks per week, and for women who drink less than 9 drinks per week. So, and you can't save them all up for one day. Okay. All right. But people who consume greater amounts of alcohol should cut back. But clinicians should not recommend, so if you have somebody who's a teetotaler, don't recommend that they start drinking to try to help reduce their coronary artery risk. Don't take it up. Okay. All right, supplements. So fish oil has not been shown to be beneficial in terms of cardiovascular disease prevention, event prevention. There was the diet and angina randomized trial, which was the DART-2 trial. It involved 3,114 men with stable angina, and they were given the advice to eat fatty fish, but that did not reduce mortality, and taking fish oil capsules was associated with a higher risk of cardiac and sudden death. The large meta-analysis that was published in 2012 by the Journal of the American Medical Association found no benefit with respect to all-cause mortality, cardiac death, sudden death, myocardial infarction, or stroke. I'm going to talk about coenzyme Q10 in a minute, but the other supplement that I didn't put on here are antioxidant supplements, and those are a no. The thought is that or L-arginine is another one, but they actually can cause significant harm, so no antioxidant supplements. Just eat them. Coenzyme Q10, so this is an endogenously synthesized lipid antioxidant that scavenges free radicals, and it's necessary for the basic functioning of cells. So it's synthesized using HMG-CoA, which is the same enzyme that is used to synthesize cholesterol, and it's blocked by statin drugs. So this can explain why statins cause myopathy and increase the risk of developing diabetes, because it blocks this enzyme. So CoQ10, it's also known as ubiquinol, but when it's used as an antioxidant in the body, it becomes oxidized to ubiquinone, and at that point, to be used again, it has to be converted back to ubiquinol. So what's interesting is that the way they just discovered how this actually works, how this conversion from ubiquinone back to ubiquinol actually happens. And when you eat green leafy vegetables and you eat the chlorophyll that's in those, this is crazy, but it's so cool. You eat the chlorophyll that's in these plants. If you put a light under your hand, right, you can see the red light shining through. So it can come in, the red light can come in from the sun, and it interacts with that chlorophyll that's in your system from eating the green leafy vegetables, and it actually is that's actually what converts this ubiquinol back to, or ubiquinone back to ubiquinol for reuse to synthesize CoQ10. So go outside and have a salad. Okay, physical activity. So again, everybody knows moderate physical activity, 30 to 45 minutes, 3 to 5 times a week, is good for you. But it's important to know that it is not required for heart disease reversal. So you can sit somebody on a couch, and as long as they're eating in a way that's reducing their cholesterol levels to the appropriate, to less than 70, you can still reverse heart disease without exercise. And that's actually, it's a good and a bad thing, right? Because we say, well, we need to get people exercising. I agree. But people with significant coronary artery disease or cardiovascular disease that's all throughout the body, these folks aren't going to be able to do much in terms of activity. So it's important that, that you just understand that. Okay, and then antiplatelet drugs. So people without cardiovascular disease should not be just taking aspirin, a baby aspirin, or whatever kind of aspirin for fun, okay, for prevention. It's really for secondary prevention only. So people who've already had an event who are trying to prevent a second event. And in those patients, the recommendation is either 81 milligrams or a baby aspirin per day, plus or minus clopidogrel. Because we know that, so the numbers are that for patients who have already had a cardiovascular event, if you treat 10,000 patients with a daily aspirin, you prevent 250 recurrent events. So in this same group, you're going to have 40 major extracranial bleeds, which is a ratio of 6 cardiovascular events prevented for 1 new aspirin-related bleed. So it definitely, for individuals, those individuals, the benefit is clear. But for primary prevention, if you treat 10,000 people, you'd prevent 7 cardiovascular events, but you'd get 4 hemorrhagic events, which means that's a 7 to 4 ratio, less than 2 to 1. Optimal dose and duration are unknown. But again, we talked about the baby aspirin is preferred because it minimizes the risk of bleeding, particularly when it's going to be used with other antithrombotic drugs. And about 10 to 20% of patients taking aspirin for secondary prevention, ischemic events recur. So an aspirin, it has an anticoagulant effect, but it also has an anti-inflammatory effect, which is why it's used in prevention of preeclampsia in women who are at high risk. But interestingly, aspirin is a salicylate, right? And what we know is that the salicylates that are in plant foods, especially herbs and spices, when they're consumed at culinary levels, can actually they have an anti-inflammatory effect, but they also have this anticoagulant impact, but no increased risk of bleed. And sleep and stress management. Again, we know that people who have established cardiovascular disease, stress and poor sleep habits can increase inflammation and precipitate events. Again, everybody should be getting 7 to 9 hours. And if you've got somebody who has cardiovascular disease, it's probably really important that you assess them for sleep apnea because having sleep apnea increases your risk of sudden death. Okay, and I think that's it. Any questions? I tried to talk fast, sorry.
So those people that are 106 and say they had a drink of liquor every day, that probably.
Yeah, I mean, I think 1 a day is probably okay. Yeah, based on the large studies that we know. So, yeah. Mm-hmm. So curcumin, which is turmeric, cumin, cloves, oregano. There's one more that was kind of a big one. I'll have to think about it. But I mean, if you just go online and look, but yeah, most of those 4 in particular.
Was Finland able to hold on to their improvement numbers over the course of time, or did they revert back?
That's a great question. So, so that question got asked 2 years ago at so Pekka Puska, who was the man who was responsible for getting this initiative rolling back in 1972. He was a speaker at one of the ACLM conferences a couple of years ago. And the answer is largely yes. They did start to have some backsliding within the last about 10 years of people reverting back to, you're starting to see the butter consumption start to increase again, and some of those dairy products start to increase again. But yes. So they're still doing way better than we are, but they have started to see some backsliding. Mm-hmm.
I had a patient in the office recently that asked me about a book called The Big Fat Surprise by Nina Teicholz.
Okay.
A science journalist and researcher. And I said, well, I'll ask that.
Yeah. So,
Published in the British Medical Journal, and it seemed to be received well among
yeah.
in the nutritional science area.
Yeah, there's been a lot of controversy with Nina and the BMJ, and there was something. I'd have to go back and look, but somebody wrote a response to that in the BMJ, and then the BMJ either didn't publish it or published it, but it was delayed or something. And I have not read her book, so I can't really speak, to what the content is necessarily. But what for me personally as a physician, when I read the China study, my first response was I was super angry. I almost used the word. I was super angry because I didn't learn any of that stuff in medical school. And the more and more that I have delved into the literature, it's become pretty apparent to me that the things that Dr. Esselstyn and Dr. Greger and Dr. Furman and all these other Dr. Campbell, all these other people are saying are true, and they back it up with data. And so I have a hard time. Like I said, I haven't read her book, so I can't speak to it necessarily. But I would have a hard time going along with the opinion of a science writer. Not to say that she's not educated on the subject, but
Criticizing Ansel Keys and they cherry picked, but somebody recently told me that Ansel Keys retired in Italy, and his housekeeper, this is true, believed in eating extra virgin olive oil, at least a liter a week.
oh my gosh.
The reason to do that, she said, it reflected his attitude that salads were one way of getting olive oil into your milk.
Right, yeah, and so what's interesting is we've gone they've done some studies where they've gone head to head. I mean, the Mediterranean diet, absolutely, it's better than the standard American diet. There's no question. Even with fish and olive oil and those things, absolutely, it's still way better. But how does it compare to a whole food plant-based diet? And can you actually, the reality is that we have clinical evidence of the ability to reverse, clinical and radiographic evidence of the ability to be able to reverse coronary atherosclerosis with a whole food plant-based diet. So, if you want to say, well, this epidemiologist cherry-picked data, okay, but what about, I don't know how you refute the other piece of it. So I need to read her book. To be fair, I should do that.
The other point, and I didn't catch the early part of your presentation, but there's an attitude out there, if you will. This comes like Mark Hyman and William Davis, that the grains we now eat are not the grains we ate, and we're in the heartland of glyphosate land.
Yes.
And all the chemicals, shouldn't we be eating clean foods? And
Yes.
sure we're eating organic or following the Environmental Working Group, at least minimizing
Yes.
herbicides, pesticides, because as a microbiologist, I look at it through the lens of a microbiologist
Correct. Yes. And I didn't bring up the fact that, choline, when we consume choline, depending on your dietary pattern, that impacts your gut's ability to handle the choline, and you can produce TMAO, which, makes the heart disease progress. You're absolutely right. So, my day job is that I'm the director of the Institute for Human and Planetary Health. So my focus is on the connection between food as it is impacting our health directly in terms of what we choose to eat, but then also how that food is produced and how that's impacting the environment around us and how that impacts the quality of the food, and then how the food that we're producing causes climate change and environmental degradation that's also impacting our health. So I 100% agree with you. And the interesting thing about glyphosate, and I'm going to talk about this in the gut microbiome series, which is it's in October, is that it is what they believe is causing non-celiac gluten sensitivity. So celiac disease is a genetic disorder, but now you're seeing all these people who are eating gluten-free because they have all this, right? They think that they're gluten intolerant. And it's not so much that they're gluten intolerant, it's that the glyphosate the Roundup that's so predominant in the diet, in the food supply, is causing leaky gut, which is causing the gluten to be able to pass through the gut wall, and then that's what's actually causing the problem. So it's not gluten, it's the glyphosate. Yeah, so you're totally correct. And the nutritive value of the fruits and vegetables that we're eating is being impacted by carbon dioxide levels in the atmosphere, and it's declining. We got a lot of problems. Yeah.
It's terrifying.
It's absolutely terrifying. I'm in complete agreement. I try not to go around like scaring people, but anyway, I agree with you. So, okay, thank you so much for coming. I really appreciate it.